I should say it's not only a brief but a very fast run because I have allotted time is very less. See, development of radiology imaging. The last 50 years was tremendous and amazing, as you know. When I started my career in 1969, you know, it was everything based on X-ray, nothing but X-ray. Plain X-ray, more than 300 or 500, and all other investigations done by X-ray alone, different forms and different methods. A good plain X-ray at that time was able to give a diagnosis of acute appendicitis and acute pancreatitis. You know, at that time there was no ultrasound, no CT, no MR, but more or less always we could diagnose almost accurately from a plain X-ray correlated with clinical and other lab findings. But now the imaging modality is so developed, the conventional imaging is going back. But as an old person in the department, I cannot forget that old conventional methods. I will make a quick turn to the old imaging modalities and nowadays body. Let us see. So development we see is from X-ray imaging to ultrasound, CT scan, MR scan, PET scan, and the commander. And now it is reached up to the stage of artificial intelligence with radiology. So it will be going to under 10 years or so, it is going to make another step very fast run. See, plain X-ray already told you, if a good plain X-ray can give you so many. Dr. Ali has already said how X-ray chest is being read. Similarly, abdominal X-ray, we used to diagnose, I told you, acute appendicitis, many other things we could diagnose. Even mass lesions from the pattern of gas pattern under the bowel lobes with the barium meal and IV, we could say. Investigation done in that stage, the department was so busy. Barium studies, about 10-15 barium meals daily, 5 or 6 IVPs, and angiograms, and cystoidograms, cholecystogram. Have you ever heard of that cholecystogram? We used to daily 1 or 2 cholecystogram. Lymphangiogram, you know, whenever abdominal or pelvic nodes are suspected, we used to do lymphangiogram and take serial pictures of pelvis and abdomen to get the nodes. Nowadays, you cannot imagine such a procedure. We used to do that. And myelogram, nobody does that. Fistulogram, bronchogram, a simple bronchogram, person sitting on a chair leaning back, and thyrocoracoid membrane just punctured with a thick needle, and we put oily dye and take in different positions. Good bronchogram film giving all the details. It's a crystal of calcium, we could diagnose like that. Now nobody does that. Thyrogram, hysterosound, I have parted in whatever I read, it is even being done today and useful in many ways. PTC, percutaneous transhepatic cholangiogram. Already the interventional radiologist said something about that for intervention and drainage for the obstetric jaundice. But we used to do for diagnosis, whenever obstetric jaundice was suspected, the extrahepatic, because there was no ultrasound, we used to do percutaneous transhepatic cholangiogram and take the X-ray, get a beautiful outline of all the biliary radical, so you could make a diagnosis of the cause and site of obstruction in many cases. And he wanted we could take the train percutaneously and relieve the obstruction also for give a comfortable end to the patient. And pneumoperitoneum, have you ever got down? But I am sure that most of you might not heard of that. Whenever a mass, especially retroperitoneal, any mass in the abdomen, the procedure was plain X-ray, barium meal, IVP, then contrast, venogram or aortogram, and find sometimes pneumoperitoneum. We introduce air or carbon dioxide through the retroperitoneum, which may be in the pre-circle area, and take pictures. So it will obtain beautifully kidneys, adrenals, liver, and all the beta structures so beautiful as if written but drawn by like that. So nowadays nobody does. So it was a past. And now Usually done is these are the investigations. Barium solo, barium meat, barium enema, IVU, retrograde pyelogram some cases, cystourethrogram both maturating and ascending, histosangiogram and angiogram. I am not going to detail angiogram. Already you have seen enough of angiogram how it is useful. But routinely in diagnosis of any abdominal tumor, we used and also carotid angiogram daily we were using in department 5 or 6. Pneumoencephalogram, contrast ventilogram, everything was so busy department because of all these invasive procedures. And this barium solo. Now the limited indications, especially after corrosive poisoning, you want to see the extent of the stricture and also the functional status of the declusion process, we do this. And also in children, when there is a reflux vomiting, usual vomiting, newborn and infants, it's a common problem, mother saying frequent vomiting. So in that case, you do barium solo and barium meal in children. So barium meal picture, barium solo picture, barium. This is a barium solo showing a stricture at the midline. Midline is a stricture, can beautifully say that. See, this all point we know achalasia cardia. It's a normal barium meal in the erect posture. Why I say erect posture? Because fundal gas is seen with a fluid level. You can see the fundus, body, pyrorachondrum, and there is an incisor that is the butyrperistalsis, pyloric incisora, duodenal cap, C-loop. Normal anatomy is very important at that time because where is the duodenum is proper. This is the first part is the intraperitoneal, this is retroperitoneal, third and fourth row is also retroperitoneal because that will displacement will help us a lot to come to conclusions in abdominal mass lesions. Sorry. For the delayed picture showing the jejunum, see this is a DJ flexor, jejunum all over in this area, not here, and ileum coming to this area. So this is the distribution and this is a prone film because fundus is full in supine, but how this is like double contrast in prone film. We used to take day pictures. This is a barium solo with beam. Can you diagnose somebody? This is first film, second film. In taken tendon, hiatus hernia, a portion of the fundus is going into the thoracic cavity. Oh, ingot open. കാണാമേ കേട്ടോ ഇവിടെ കാണിച്ചത് എനിക്ക് ഇതാണ് ഇതാണ്. This is normal barium enema. See the postural markings, which actually is a partial double contrast film. This is the terminal ileum, a portion of appendix is visible, normal pattern. Now let us see some abnormal rapidly. This is a benign gastric ulcer. This is a profile view and this is a profile view and that is the end-on view. You can due to the puckering of the mucosa you can see radiating folds. So this is end-on view of the ulcer. This is a profile view. You can see in the hand and line like that. This is normal already you have seen. This is abnormal ileum, ileocecal, and also there is some defect here also, ileocecal tuberculosis. Another barium minima showing a filling defect here having a pincer shaped appearance, classical picture of intersusception. And at that time industrial barium was used to reduce the intercepts also. When we give barium insulin, usually what happens is it will reduce. So it was used like that. It's a picture of the desmosectoctic region. Actually it may be malignant structure because and growth, infiltrating growth could be. IVU, even nowadays it is done, so everybody knows the indications, but not in all cases we do, because just to diagnose as your renal function in a stone we don't do now, because easily it is done by ultrasound. But at that time, for everything, any renal problem, we used to do IVAVP. This is a normal calyceal pattern, cupping. All the calyces are directed outwards and outline is seen clearly, ureter, bladder. But here what is happening? Pelvical system directed medially, and the kidneys are, instead of like that angle, this is like that, set horseshoe kidney, fused at the pole, rover pole. Is a calyces cupping is gone, blunting of the cornices, and pelvis is dilated, ureter completely visualized. So it is a hydro-ureterocalicosis. And left side non-functioning, either it is hydrophorus non-functioning or absent kidney, because we don't have an nephrogram there. This is elongated irregular calyces, and here you see a filling defect. So this must be growth in the bladder or clot. We don't know because bleeding. If the clot says irregularity is there, so it must be a growth. Duplex collecting system, completely duplex here with a fused kidney, and here it is incomplete duplex. Here ureter is also 2, here the incomplete duplication. This is a classical true-Bingley appearance. So this is top down, and there could be a mass here. Usually this is seen in a double moiety with the non-functioning hydronephrotic upper moiety or a mass there. So this must be pushed down. Children, nowadays also this is done very often, because to see the assessment when baby complains of maturating difficulty, and when we do, this is a normal cystogram, cystourethrogram, maturating posterior urethra and bulbar urethra. Here compare this, there is a posterior urethra so much dilated, is a valve, posterior urethral valve. This is an ascending urethrogram. See the catheter there. There is a stricture, posterior urethra it's a stricture. It's a child X-ray, infant X-ray, barium is showing. This is supine film because fundus is full. And you see, it was taken after complete this is done under fluoroscopy and taken. So this is you see the contrast filling the lower end. It's a reflux. This is usual cause, one of the usual cause for vomiting in children, newborn. Anybody can give a diagnosis here? A side of newborn actually. This is hypertrophic pyloric stenosis, long, narrow, this thing. And this usually nowadays this can be easily diagnosed by ultrasound also. This is what happening here. I have already shown you a normal barium meal with filled ileum and jejunum. What is happening here? Supine film, cap, second part, third portion, dural refractor is pushed this way. All the jejunal loops here is this way. Baby is having vomiting, frequent vomiting. So diagnosis malrotation with large band. This is the usual cause for, one of the usual cause for vomiting in infant. So again, in malrotation different type, incomplete or complete. According to that, cecum may take its position varying area. Here the cecum is here, the transverse colon is here, descending colon like that, going that. So it's a malrotation of the intestine. In gynecology also, conventional radiology still use the gold standard for tubal block study is actually hysterosalpingogram. At that time also we used to plenty, but the number now has reduced. But still, why we now number reduced? Because of non-radiology, sonosalpingography is done because there is no risk of radiation. But the problem is the sonohysterosalpingogram with that documentation is difficult. Only you can see by ultrasound spillage, but documentation is different. But here documentation is so it's gold standard. Here you actually as normal uterine cavity, this is a cornua, tube, ambularian, and this is spillage, pre-spillage. So both tube are normal, uterine cavity normal. Here, see both tube blocked. Here there is like nitrosalpine and both that plane. This is a biconvate uterus, you see, with no spillage. Tube can be, tube is studies there. You would have there doubtful spillage is there, but not sure. This is what is happening. See, there is a compression. A submucous mass, probably fibroid should be there. Now, what is easy to confirm it by ultrasound. See this. Usually, if it is a septate uterus, this area will not be concave like it will be usually this area may be a little different. So, another possibility or DD is a thick septate, incomplete septate uterus. Anybody give a diagnosis here? It's a usual happening in hysterosalpingogram. You might think it is spillage, but it is not. This is a uterovenous intravasation. That means if the investigation is done before bleeding stops, or if the sinusoid soil is still open, or traumatization during the investigation, the contrast goes to the uterine plexus and then will be trained to the other way, iliac. So this is the uterine plexus, there is no point in further doing now the investigation, postpone investigation, because there is a uterovenous intravasation. This is a classical picture of endometritis and a small cavity with additions. Uterine synovitis it is called, and both this tube is blocked, but this tube also ambularian blocked. So this is small. So usually this causes endometrial tuberculosis. I think that's the last. Thank you for the personal listening.
As we are behind time, we will have a small Q&A session. If anyone